So, welcome to my case study. I'm Jessica, and I'll be presenting on diastematomyelia, which is a spinal abnormality. It usually presents in neonates, but it can present later on in life with symptoms. So, I'm going to be going over a general overview of the abnormality itself, as well as the specific case study, the specific clinical presentation, and treatments within this case study. I'm going to be going over the etiology and the pathophysiology with what causes this abnormality, the clinical presentation, such as symptoms, and the diagnostic imaging appearance, including ultrasound and MRI, magnetic resonance imaging. I'm going to be going over diagnostic criteria, how you diagnose it, the treatment, and a conclusion, which includes, again, just like the general overview. I'm going to come back and talk through everything that we went over. And at the end, I'm going to include all of my references and where I got all this information. So, the general overview with this abnormality, it's a congenital spinal cord anomaly where the neural tube fails to fuse properly and you end up having two hemichords. Now, this can be caused by either bone, cartilage, or fibrous septum. And as you see in the image, there are two separate characterizations. The first one being a bony septum, and this one usually causes two dural sacs. And the second image to the right shows a split by a fibrous septum, which is usually, this one usually ends up having one dural sac due to just the nature of the abnormality. So, with this type of anomaly, an MRI is the imaging modality of choice, just because does deal with being near the vertebrae, and sometimes it can be hard with ultrasound to penetrate through to the tissue below. MRI is the imaging modality of choice, especially under or after 3 months, because under 3 months, the bones are not completely ossified. The abnormality shows up as a mass in the spinal column with two splitting cords. Again, it could be bony or rigid. It could be fibrous, more flexible. Usually, the treatments include surgery to remove the mass or close monitoring for milder cases that don't present with as many symptoms or just milder cases in general. So, for this specific case study, it's on a 5-month-old female who demonstrated with neurological symptoms around 4 months old. At birth, everything was normal. It was a smooth birth, no abnormalities visualized, everything prenatally, all of the ultrasound scans, they were normal as well. But around 4 months old, the patient presented with asymmetric reflexes and muscle weakness. So the parents of the patient wanted to hold off to bring the child in, but it got to a point where they noticed the neurological symptoms began to worsen. So they brought in the 5-month-old, and the physician did a clinical assessment and found that there was a abnormal hairy patch, a sacral dimple, and hypotonia, which is muscle weakness, specifically mostly seen in the legs. Now, there was no relevant patient history that may indicate this abnormality, but the clinician decided to order an ultrasound and an MRI just to show just to get imaging and get it visualized. And both images showed two hemichords at the L4 level, at the L3, L4 level. The patient ended up being referred to surgery to remove the septum because it was causing these neurological symptoms. Now, some etiology on the abnormality. Diastematomyelia is a congenital defect. Although the exact cause is unknown, there's not too much research on this topic because it is more rare. It does fall under the umbrella of spinal dysraphism, which is an incomplete closure of the neural tube, which usually happens around the 3rd to 4th week of gestation. And because of this, it usually does not close on the caudal end of the tube, causing abnormality in the sacral and lumbar region. Some of the associated abnormalities with this anomaly include a tethered cord and congenital scoliosis, which is the biggest factor when it comes to diagnosing it. Although this patient did not experience either of those, causing it to go unknown for another couple of months after birth. So some of the more in-depth studies of the pathophysiology of this anomaly. Again, it is an unknown embryonic origin of what causes the spinal cord and to not fuse properly. It is thought to be because of the accessory neuroenteric canal, which is the canal between the amniotic sac and the yolk sac, and it's thought that those two don't fuse properly. And again, it is a congenital spinal abnormality, so it doesn't present anywhere else than the body. Although it is most common in the lumbar and sacral region, it can present in the thoracic region. So some of the clinical presentations. This patient presented with leg weakness, or most commonly known as hypotonia. Just like this image to the left shows, we can see the baby has abnormal muscle tone and cannot hold himself upright and cannot move as well as you might expect at the 4 to 5 month mark. Some of the other symptoms that this patient presented with are some cutaneous lesions, two of which being hypertrichosis, which is a hairy patch in the lumbar region, just above the buttocks, and a dimple in that area as well. Some of the other symptoms that are common with this anomaly include back pain, which is usually in older patients when they are able to present that. Some paresthesia, some scoliosis, which is the biggest factor in this anomaly, and again, some cutaneous lesions, including a lipoma, which is fatty tissue mass. So some of the sonographic appearances include two hemichords, wide spinal canal, and an echogenic focus between the hemichords in this specific case. The ultrasound was ordered because they show abnormalities before the bone is completely ossified and within this age range. The first image to the right shows a longitudinal image of the abnormality at the level of the L4 and L5 region. As we can see, the bony spur in between or right above the vertebra. To the bottom left image is a transverse image taken at the level of the L2 and L3 vertebra, and it demonstrates a normal one spinal cord. The second image to the right shows an L3, or is taken at the L3 and L4 level, and just below the first one. And it shows an abnormality. It shows the two spinal cords being split off and the hyperechoic center in between them, which is the bony spur. Um, these are specific to this case specifically, but some of the other sonographic appearances that might show up on ultrasound with this anomaly include spina bifida and hydromyelia. After the ultrasound was taken, an MRI was taken the following week due to, or in order to get better images. It is usually the modality of choice due to the way that we can see better detail. As you can see on the right, there are two dural sacs, meaning it is split by fibrous septum and is more likely type 1 anomaly. It has two hemichords, and a sagittal view in MRI would show the extent of the split. So it would show what level of the vertebra and the spinal cord it starts and where it ends specifically. Bony septum on MRI is unlike an ultrasound where it shows this hyperechoic with shadowing. On MRI, it shows up as a dark area signal because the bone cannot attenuate, as well as soft tissue. So some of the diagnostic criteria, we have three main ways that we can combine and think of the diagnosis as a puzzle. So first one being imaging, of course, ultrasound and MRI are the gold standards for spinal anomalies in neonates and children. So the MRI and the ultrasound show two double cords. The second factor is clinical symptoms. We can combine that with imaging, which include paresthesia, hairy patch, and leg weakness. And some of the classifications to further divide the diastematomyelia into include type 1, which is a solid bone dividing the cord. This causes it to split into two dural sacs. And type 2 is more of a fibrous or cartilaginous septum. It's more of a softer septum, meaning it doesn't split the dural sac into two. It will be contained into one, although it still has two spinal cords. So some of the treatments when it comes to this case include surgery and monitoring. Surgery is most common for type 1 when you're dealing with bony tissue and high symptomatic patients. The surgery is used to remove the septum in more severe cases, and it usually involves a laminectomy, which cuts into the spine and removes that bony septum. Monitoring is usually for type 2 diastematomyelia because with type 2 and softer septums, you don't usually present with super symptomatic patients because it doesn't compress on that cord as much as bone might. So it's usually for those milder cases, you usually want to do a close follow-up and assess if there are any resolutions, or if the symptoms do get worse, then you might want to go ahead and continue with the surgery. Usually with these milder cases, you don't want to go in with surgery right away because of the possible risks that might come with surgery and anesthesia, especially in these younger patients. So, in conclusion, diastematomyelia is a congenital spinal anomaly that may present neonatally or it may develop later throughout life. It is not if it is not caught on to earlier. In this specific case, we talked about a 5-month-old female who had neurological symptoms, but no significant family history that may point to this anomaly. They clinically presented with a hairy patch and hypotonia, which resulted in coming to see the physician in hopes of treating them. And the sonogram was ordered and showed two main focal areas in place of one spinal cord, with an echogenic focus right in between them, causing the spling. Surgery, you can treat it through surgery in severe cases, or in mild cases, you can just monitor. And in this case, with the bony septum causing the neurological symptoms, the patient went with surgery and removed the septum. All went well. The surgery, the patient had a few follow-ups, and everything turned out normal. So thank you for listening. I hope you learn more about diastematomyelia, what kind of symptoms and how it clinically presents, as well as treatments, and how this specific case study is rare but very important to know. And these are some of the references that I use.